My name's Stephen Jan. I'm Professor of Health Economics at the George Institute for Global Health, and today's lecture will be an introduction to economic evaluation. The focus of the lecture will be on the use of economic evaluation in relation to population health programs. What you should be aware of is that there's no assumed knowledge of economics or economic evaluation, so I'm pretty much going to be starting from basic principles. So you'll see in the first slide, I have some background statistics in relation to expenditure in Australia. And as you can see, there's a trend towards increasing spending from generally all sources, in particular from the Australian government. So you can see over the last several years, there's been an increase in spending in relation to government expenditure, private expenditure, and expenditure from states and territories. And all this highlights is that there is increasing demands on healthcare resources, and so we really need to think about how we spend our resources and achieving value for money. And so that's the context in which I'd like to present today's lecture is the idea that there are increasing demands on healthcare resources, and that's a universal phenomenon, not just Australia. And we need to work out ways in which we can get value for money from our healthcare resources. So the outline of the lecture, first part of the lecture I'll just give you a very brief definition of what we mean by economic evaluation. And then I'll go into 4 different types of economic evaluation: cost minimization analysis, cost effectiveness analysis, cost utility analysis, and cost benefit analysis. This isn't an exhaustive list, but it covers the main types of economic evaluation that have been used in the healthcare setting. And then the last bit of the lecture, I'll discuss how we interpret the findings of an economic evaluation study. So here's a definition that's of economic evaluation as it applies to the health sector. It's a definition that comes from a textbook by Michael Drummond, which is probably the most commonly used resource in this area. And the definition is the comparative analysis of alternative courses of action in terms of both their resource costs and their health consequences. And as you can see, that there are a number of elements in this definition that highlight important features of an economic evaluation. Firstly, it's a comparative analysis, so it involves comparing 2 or more options. The other aspect is that it involves looking at both what goes into a program, so resource costs, and what comes out in terms of health and other consequences. And that's generally the framework that we're operating when we're doing an economic evaluation. And you can see that with the next slide. So this is a diagram that basically shows you the structure of an economic evaluation. We have 2 programs, Program A and Program B. And what we're interested in is both the costs, so what goes into both of them, and consequences, what comes out the other end. And importantly, what we do in an economic evaluation is that we value the differences in the costs and consequences between A and B. So in a sense, we subtract one from the other. Subtract the costs from A subtract the costs of A from B, and subtract the consequences of A from B. So A might be the new program or treatment, so it might be a new drug or it might be a new health promotion program, and B is usually framed as in terms of standard practice or the status quo. So what economic evaluation generally does then is assess what is the additional costs associated with moving from the status quo to the new program, and what are the additional benefits or consequences we achieve when we do so. So the fundamental principle underlying this is that economic evaluation is in a sense an incremental analysis. It looks at the incremental costs and the incremental consequences of an investment in a new program. So if we look into a bit more detail what we're trying to measure, on the cost side, there are a number of components that we are interested in. So we're interested in terms of the intervention and also the comparator, which is often the usual care. And the first component of cost is the cost of the actual intervention itself. So when we're doing the economic evaluation, whether it's a new drug or a new health promotion program, the most obvious thing that we need to cost is the cost of that program itself. So the cost of implementing that program on top of usual care. So if we have a usual care or standard practice, if we're implementing the new program, we want to find out how much does it cost to the health sector or the community to implement this new program on top of what's already happening. And that comprises a number of components, and it might include staffing, materials, and drugs. The other element of costs are the costs that are incurred by individuals that are involved in the intervention or the comparator. So these are costs of healthcare that are consumed by patients or by individuals within both groups of patients or individuals. So if we're talking about the cost of healthcare, we're talking about the costs associated with hospitalizations, primary care visits and medicines. And if we're doing a study or for instance a randomized trial of a new intervention, then what we're interested in is following up the individuals within that trial in terms of their healthcare use, measured in terms of hospitalisation, primary care visits and medicines. And we do that for both patients and individuals in the intervention arm as well as in the comparator arm, people who are receiving usual care. So they're the sorts of costs that we're interested in measuring if we're taking a health sector perspective. So essentially these are the healthcare costs, the costs that are incurred by the health sector associated with the intervention. Sometimes, however, that may be too narrow a perspective, and we might be interested in a broader social perspective. From that point of view, we might be interested in measuring broader social costs. These might include for instance, lost productivity associated with an illness or a condition that's being assessed. So if we're interested in social costs, then you might have, for instance, an intervention that keeps people out of hospital if it's effective. If that program is shown to be effective and keep people out of hospital, it in turn may enable those people to return to work earlier and be more productive. And if we're taking a societal perspective, we might want to then measure those costs or cost savings to the health system associated with a particular intervention. So in terms of how we measure those costs, there are a number of sources of data. The most obvious are financial records associated with running a study. So we generally have budget statements pertaining to how much staff, how many materials, how much training. Those sorts of things are records which enable us to determine how much an intervention costs. So this might come from a particular trial that we're running, but it may also come from questionnaires that we administer to patients or participants within a study. Sometimes we might be possible to use diaries to record healthcare utilisation. And that's sometimes quite a useful tool for measuring hospitalisations. Diaries are ways in which we can measure the use of health services from patients on an ongoing basis and not have to rely on them to remember how many hospitalisations or how many medical consultations they had over the past year if we're just relying on following them up over a long period of time. Other ways in which we can record resource use is using hospital records. The advantage of that, of course, is that it doesn't rely on patients or participants to remember their utilisations. And perhaps the gold standard for measuring healthcare resource use is using linked administrative data. In New South Wales, we have the benefit of a resource called the Centre for Health Economic Record Linkage, which often referred to as Cheryl, which enables us to link across multiple data sets and enables us to then follow up patients, not only within the hospital system, but across the entire health sector. So there's some of the practical aspects associated with the measurement of costs for an economic evaluation. I just now want to go into some of the different types of economic evaluation that are available for us to use in the health sectors. The most common, well, the most basic form of economic evaluation is referred to as a cost minimisation analysis. And the best way to describe that is if we go back to the original diagram that I showed you, and in the next slide I've reproduced that diagram but shown you how a cost minimisation analysis fits in. So you can see here we've got program A and program B, and going into both are costs and coming out are consequences. The feature of cost minimisation analysis is that it assumes the consequences of A are equal to the consequences of B. So it means that the outcomes of A and B are equal, and therefore all we have to do is compare the two in terms of costs. This is something that we can occasionally assume. For instance, if we're doing an evaluation of two drugs, one might be a generic drug and the other one might be a brand name drug, the same active ingredients, we may be able to then make the assumption that the outcomes of the two interventions are going to be the same, and therefore the comparison is really just going to be on the basis of costs. In relation to population health, that sort of comparison may be a bit more difficult to make, because it's often difficult to assume that two programs are going to be equivalent without doing the studies to determine whether that is in fact the case. So in that instance, it's always probably safer not to do a cost minimisation analysis and move on to the next type of evaluation, which is referred to as cost effectiveness analysis. So cost effectiveness analysis is probably the most commonly used type of economic evaluation in the health sector. And if we go back to the diagram, it's the same schema, program A and program B, but the feature of cost effectiveness analysis is that it assumes the consequences of A and B can be measured in the same units of health gain. So that might be lives saved or life years gained or cases prevented. It doesn't assume, like in cost minimisation analysis, that they're equal. It just means that all it does is it assumes that they can be measured in the same unit of health gain. So an example of how the findings of a cost effectiveness analysis might be presented might be in terms of an incremental cost per health gain of A versus B. So an incremental cost per life year saved of A versus B. So that's essentially the type of comparison that we're doing with the cost effectiveness analysis. We're comparing the costs per unit of health gain achieved. In this case, it's cost per life year saved. A variation on cost effectiveness analysis is cost utility analysis. It's essentially the same as cost effectiveness analysis, except the unit of measure that we have is quality adjusted life year, or QALYs. and it's essentially a composite measure of life years gained adjusted by quality of life. And I'll show you just briefly how we measure QALYs. Essentially, quality of life is measured on a scale of between 0 and 1. So 0 represents death and 1 represents full health. And a quality of life weight, for instance of 0.5, would represent some degree of impairment, which is then multiplied by survival. So if somebody has a quality of life of 0.5 and survival of 10 years, then their QALY is 0.5 times 10, which equals 5 QALYs. So it's a simple matter of just measuring the quality of life weight by the length of survival. And so when we're measuring QALY gain, we're interested in the QALY of program A subtracted from program B. So that's essentially the gain that we achieve from a particular intervention, the difference between A and B in terms of QALYs. So the final type of economic evaluation is cost-benefit analysis. And as you can see, it's slightly different in the way it's presented. It really doesn't involve a comparison between two different alternatives. It's essentially a standalone evaluation of a single program. So it looks at program A in terms of costs and its consequences. What defines a cost-benefit analysis is that the consequences of A are measured in terms of social benefits and cost in terms of social costs, but they're both measured in monetary terms. So the point here is that we generally take a societal perspective. So you remember the original diagram that I showed you? We have a health sector perspective and a societal perspective. Well, in cost-benefit analysis, we generally take a societal perspective and we measure costs as you generally do in monetary terms, in dollars. But what's interesting in cost-benefit analysis is we measure the benefit also in dollar terms, and that can pose a bit of a challenge when we're evaluating healthcare programs. So the question rises: how do you measure the benefit of a healthcare program in monetary terms if the aim of the program is to save lives? Well, there are ways in which we can do that, and I'll show you in the next slide. But essentially what we're trying to do with the cost-benefit analysis is if we can measure the cost and benefits in dollar terms, then it gives us a very simple decision rule when we're assimilating the results. So if the benefits exceed the costs, then what it says is that overall, in terms of the community, we should go ahead with the program. If the value of the program is greater than the cost, then we should accept the program and invest in it. If the benefit of the program is less than the cost, then obviously we reject it. So it enables us to boil down the decision in relation to funding or not funding a program on the basis of a simple comparison of the benefit versus the cost. And if the benefit's lower than the cost, we reject, and if benefit's higher than the cost, we accept. Often it's presented as a ratio. So you may have heard people refer to benefit-cost ratios, and obviously if the benefit-cost ratio is greater than 1, then it means that we should accept and fund the program. So I'll just go back to that question I raised earlier. How do we value benefits in dollar terms? Well, there are two ways in which we can do it. One is to value the benefits of healthcare programs using what's known as a human capital approach. That means valuing human life or survival in terms of the productivity of the person whose life you're valuing. So if you, for instance, save 10 years of life as a result of an intervention, that may translate into 10 years of productive capability for that person, so 10 years in the workforce. We then value that benefit in terms of the wage that person would have earned in that 10 years.
So that's a fairly crude way of measuring the benefit of a healthcare program, but it is an approach that has been used in the literature. Another way of valuing benefits is to use what's known as a willingness to pay, and that's essentially involves asking consumers or the users of a program how much they're willing to pay for it. So for instance, if we have a new program that's potentially going to prevent road accidents and people and reduce the risk of death for people who may benefit from it. Well, one way of valuing that program may be to ask users of that program how much they're willing to pay, for instance, in extra taxes per year. And that's essentially a way in which we can ask people to value a healthcare or a health sector product much in the same way as we value things in the marketplace. So the rationale behind this is that the value of goods and services that we transact on a day-to-day basis in the marketplace is essentially based on how much people are willing to pay, how much consumers. So we're now sort of transposing that principle to the healthcare setting and asking healthcare users how much they're willing to pay in order to gain a valuation of that particular product. So they're the ways in which we conduct an economic evaluation. So I've gone through the four main approaches: cost minimization analysis, cost effectiveness analysis, cost utility analysis, and cost effectiveness analysis. And as I mentioned, cost effectiveness analysis is probably the most commonly used in the healthcare setting. I'll now just go through a few slides just to explain how the findings of a cost effectiveness analysis are presented and how they might be interpreted. So we have, once again, that example of treatment A versus treatment B. Treatment A costs $800 and increases life expectancy by 1 year. Treatment B costs $500 and increases life expectancy by half a year. So in this instance, we could probably assume fairly safely that treatment B is probably the status quo option, the standard care, the usual practice option. Treatment A is probably the new intervention. So when we're doing cost effectiveness analysis, we generally do it in relation to programs that may cost more but have a claim to greater effectiveness. And that's the case in this example. So this new program costs a bit more, $300 more than the old program, but has an advantage of increasing life expectancy by an extra half a year. So we can plot that. We can plot that in this diagram here. Treatment B improves life expectancy by half a year. Treatment A improves life expectancy by 1 year, but A costs $300 more than B. Another way of plotting that is on what's known as an incremental cost effectiveness plane. So you can see here that the intervention that we're looking at is more effective but also more costly. So it belongs on what's known as the northeast quadrant. So that's where that red dot is. And that represents a situation where the new treatment is $300 more costly than the existing treatment, but is half a year of life in terms of effectiveness more effective. So it's costing more, but we're gaining more from the program. There are programs that sometimes new treatments sometimes are more effective and less costly. In those instances, as a decision maker, we have a fairly sort of simple choice. So if the new program is saving money and more effective, then what we have is a situation where the intervention sits on the southeast quadrant and the new treatment dominates the old. Likewise, or conversely, if we have a new program that is more costly and less effective, then it's being dominated by the existing treatment. in that instance, the new program belongs on the northwest quadrant. Finally, we have the situation in the southwest quadrant where the new treatment is less costly but less effective. And this is probably a situation that doesn't occur very often in a high-income country setting where we're considering a new treatment that's actually less effective than the old treatment, but we would potentially fund because it simply saves money. It might be a live policy option in a much more resource-constrained settings, but generally speaking, in a high-income country settings, it'd be difficult politically for a government or a healthcare funder to invest in a new treatment that's less effective purely in order to save money. Okay, so the way we can, the example that I gave you of this new program in terms of costing $800 versus $500 and saving 1 year of life as opposed to half a year of life can be now presented as an incremental cost effectiveness ratio, which is essentially the punchline in an economic evaluation, the summary statistic, the final sort of number that we generate when we're doing an economic evaluation. And essentially, in this example, what we come up with is an incremental cost effectiveness ratio of $600 per life year gained. So we have an ISA of $600 per life year gained. The question that poses is whether it's cost effective. So from a government's point of view, is it value for money, and is it something that we should be investing in? Thankfully, there are thresholds that are available that governments can use as a benchmark for determining whether various ISAs represent cost effectiveness. So the UK has published a cost effectiveness threshold through the National Institute for Clinical Excellence, and that's at £30,000 per quality adjusted life year gain. So what that means is that if we come up with an ISA that's less than £30,000, it would be considered cost effective. Anything above £30,000 would be considered not cost effective. In Australia, we don't have an explicit threshold. We have something that's been implicitly derived from decisions that have been previously made by government. And generally speaking, the threshold falls in the vicinity of $50,000 to $70,000 per quality adjusted life year gain. So anything below that is cost effective, anything above that is generally not cost effective. WHO has threshold as well. It's published and it's generally been used in context of low and middle income countries, and it's set at 3 times per capita gross national income. The point of all these thresholds is that it gives decision makers and people who read these cost effectiveness analyses some sort of benchmark to determine whether an ISA represents value for money or not. The problem, however, is that a lot of these thresholds are being arbitrarily set, but they've been used and basically take on a life of their own. So the initial setting of these thresholds has been pretty arbitrary. They take on a life of their own, and everybody starts using them, and they continually then get cited. So just a very quick example of how a cost effectiveness finding is presented in the literature. So this is a study that I was involved in a couple of years ago that evaluated the cost effectiveness of a text messaging program for the prevention of recurrent cardiovascular events. So basically it involved sending out text messages to people who've been discharged from hospital following hospitalisation for a heart condition. And the text messages were generally providing information and reassurance about lifestyle modification, so advice about smoking cessation, exercise and diet. And the trial that was done showed that the intervention was very effective in terms of reducing risk factors for cardiovascular disease, particular blood pressure and smoking and cholesterol levels. So we used that data, we conducted an economic evaluation, and we modelled the impact of the intervention if it was being rolled out to a target population of 50,000 patients. And we predicted that in that 50,000 patients, we would see 563 fewer myocardial infarctions, 361 fewer strokes, 1,143 additional quality adjusted life years, and an overall saving to the health system of $10.5 million. So in effect, what we found was that the intervention not only was health improving in terms of all those outcomes, but also saved the healthcare system money. So what it meant was that if we refer back to the slide earlier showing the incremental cost effectiveness plan, we had a new intervention that was sitting in the southeast quadrant. It was both less costly, because it saved money, and more effective than the status quo. That was the findings of an economic evaluation, which showed results which were pretty emphatic, but it indicates a way in which we can sort of present the findings of our economic evaluation in the context of that cost effectiveness plan that I showed you earlier. So, in conclusion, just some main points that arise from the presentation. Economic evaluation is a tool essentially for guiding the way in which we allocate resources within the health sector. There are 4 types of economic evaluation: cost minimization analysis, cost effectiveness analysis, cost utility analysis, and cost benefit analysis. When we're interpreting and presenting cost effectiveness analyses, cost effectiveness thresholds can be useful for determining whether the findings of our study, interpreting the findings of our study and determining whether the intervention is cost effective or not. The problem with these thresholds is that they're generally arbitrarily set, but nonetheless they're probably they're widely used and, in a sense, take on a life of their own. So that's essentially the economic evaluation. Thank you.